All right, so again, welcome this evening. It's really a pleasure to have everybody here, and thank you for being here. So first, I have one disclosure, which is not relevant to what we're going to be talking about. And actually, I had my slides backwards, so I apologize. So first, I want to start by thanking Connecticut Brain Tumor Alliance and the National Brain Tumor Society, who have partnered with us in support of this seminar. They are wonderful organizations who really help and support patients with brain tumors, and we are grateful for their support and their partnership. I want to talk a little bit and introduce Susie Beris to all of you. So she has become my dear friend. She was my patient, and she was practicing as a pediatrician in Connecticut, very beloved pediatrician. And one day she had a seizure in her office. She was then diagnosed with a glioblastoma in her motor strip. And so she was transferred to a local hospital and was told that her tumor was inoperable because of its location in the motor strip, and that a biopsy was offered. Susie, being a physician, thought to see if maybe there were some options or alternatives, so she sought opinions throughout the Northeast corridor. I was thankful and privileged enough to be the one to end up caring for her. I performed an awake craniotomy on her. We removed all of the tumor safely. And this is a picture of her and I at the Connecticut Brain Tumor Alliance Path of Hope 2 weeks after her surgery. They have their annual 5K. She ran it twice, and I walked it once. So she is an amazing person, and in gratitude for her success, she's now almost about 4 years after her surgery. In her gratitude, she has been incredibly generous to us and to our program. And so we recently named our Neurosurgical Oncology program in her honor. And her funds support this seminar as well as other efforts to try to educate the community, patients, and providers about the importance of brain tumor care and brain tumor management. So very grateful to her and to her friendship. So tonight, my portion of the talk is going to be talking about surgical strategies for primary brain tumors. We have Zach Corbin, who's going to follow me, talking about neuro-oncology approaches, Bruce McGibbon's talking about radiation oncology approaches, and then probably the most important aspect of the talk, Brian Jin talking about, from social work, talking about the management and support of patients and their families. So again, one disclosure that's not relevant. So we are fortunate to perform the most number of brain tumor surgeries each year in Connecticut and care for the highest volume of patients. We do try to partner with the community in that a lot of the community neurosurgeons and other providers will refer patients to us for more complex cases, and I'll show some examples of where and how we can be helpful. All of the tumors that we operate on undergo what we call whole exome sequencing, which is a really next generation sequencing technique that allows us to understand the tumor from a molecular standpoint. And that enables us to treat people from a very precise and personalized manner. And we discuss every patient in our multidisciplinary tumor board, which I direct, and everybody here attends, as well as our precision brain tumor board each week. These are just an example of some cases. I always show my patients the pre-op and post-op scans. I don't know if you're seeing my mouse or not, but pre-op is on the left, post-op is on the right, and you can see, for instance, a glioblastoma near and in the motor strip that was gross totally resected, some more aggressive meningiomas that we manage and take care of. Again, vestibular schwannomas, which we'll talk a little bit about, intraventricular tumors, and again, pre and post-op with the comparisons with showing the extent of resection, and we'll talk about how removing as much tumor as safely as possible is really the goal to any type of neurosurgical care for brain tumor patients. So the goal of primary brain tumor surgery, of course, to establish a diagnosis and to establish an accurate diagnosis, to maintain improved quality and quantity of life. And by what I mean by that is that there's great evidence that shows the more tumor we're able to remove safely, the better the patient does. This really has shown effect across all tumor types, maybe without the exception of lymphomas and small cell lung cancer, but otherwise brain tumors benefit from being gross totally resected, and patients benefit from the resection while maintaining their neurological function or even improving their neurological function. How do we do that? And so similar to Susie's tumor, patients can be told that they have an inoperable tumor because it's in an eloquent part of the brain, an eloquent meaning a highly functioning part of the brain. And so what are the secrets to the success? We have all the gadgets and gizmos that we need in our state-of-the-art operating rooms with GPS systems and ultrasounds. We're the only center in the state to have an intraoperative MRI, which I'll show the benefit of. But really, I think a lot of it comes down to expertise and experience. And in fact, that has a lot to do with more sophisticated microsurgical techniques, and especially when we're talking about preserving function. And really, the gold standard for that is neuromonitoring or use of neuromonitoring and functional mapping, as well as awake surgery, which I'll show some examples of. This was a slide that was given to me by the chair of Mass General Neurosurgery, and I really like it because I think it speaks volumes. This is, as you can see, as the case volume increases, and this is the percentage of cranial specialization. What this shows is that surgeons who do higher volume and are more specialized in a particular area of neurosurgery, cranial versus spine, and I would even argue tumor versus other aspects of neurosurgery, have better outcomes in terms of their patients. And that's certainly something that we see here. I have a short video, which I hope you don't mind me sharing. Unfortunately, I have to pull it up elsewhere. But this is a great example, and I've shown this before, so forgive me if you've seen my talks before and have seen the video, but I think it's a real great example of what we're able to do.
To a Fox 61 exclusive.
Can you hear it
it's
okay?
A nightmare scenario when undergoing surgery, waking up in the middle of the procedure and knowing what's going on. But in some cases, that can be a lifesaver.
Lifesaver and necessary. We're going to explain that in a moment, but first we do want to introduce you to a man named Andy. Andy is a husband and father of 2 kids and a nurse. Another interesting fact about him, he's also a professionally trained singer. He's even performed with his church choir at Carnegie Hall. But Andy felt his entire life come to a halt when he was diagnosed with brain cancer. He needed surgery to remove as much of a tumor as possible, that tumor in the part of his brain that controls speech and, yes, singing. That's where a special surgery comes in. Surgeons at Yale New Haven Smilow Cancer Hospital have perfected a procedure called an awake craniotomy. They invited us into the operating room, and we did not hesitate to see this incredible procedure firsthand. In an operating room at Yale New Haven Hospital, doctors are working to remove a tumor from the brain of a 31-year-old man named Andy. He is a singer. Yeah. A husband and father of 2. For most surgeries, waking up in the middle of the operation would be a disaster. But not today. An anesthesiologist doing his best to make sure Andy does just that.
Stay still, Andy. We're good. Andy, stay still.
Surgeons have drilled through his skull and have already begun to remove part of a tumor located on the left side of his temporal lobe, the area which controls language. You're doing great. Medical staff puts a microphone on him. It's not for our cameras. It's so the entire room, including the operating surgeon, can hear what Andy has to say. The procedure is called an awake craniotomy.
I do have a headache. I was telling you earlier, I don't know if it's from the brain surgery or the fact that I haven't had a cup of coffee this morning.
Neurophysiologist Brooke Callahan sits next to him and begins her work.
I am going to say a sentence, and I want you to repeat it after me. The seashore smells like salt.
The seashore smells like salt.
Their interaction can be heard on a speaker throughout the room. Neurosurgeon Dr. Jennifer Moliterno has mastered multitasking, operating, and listening.
Yeah, he's doing great.
Dr. Moliterno and her team work diligently to remove as much of the tumor as possible. What she can't see are critical microscopic language fibers which are splayed over the tumor.
The best way to try to remove as much tumor
and preserve his language is to do it with him awake.
Get too close to those critical fibers, you'll know it.
What do you do in a chair?
I don't know.
Okay. Yeah, a little bit of confusion.
So that's a great way to me to tell me to stop. And so even though there might be a little bit of tumor there, the risk and benefit of removing that tumor and having him not speak for the rest of his life tells you exactly what the right decision is. If he was asleep, I would have had no idea.
As Dr. Moliterno continues operating in a safer spot, Andy surprises us when this happens.
He does.
In the middle of surgery, Andy, a classically trained singer, shares his talent. 2.5 hours into the procedure, Dr. Moliterno decides it's time to wrap up.
The surgeons are done with the first part of the surgery. So what's happening now is they're bringing in an MRI machine and they're going to look at the work that they did and see how much of the tumor they were able to remove.
We go into another room and are able to sit with Dr. Moliterno as she analyzes her work. The before
Here is the tumor.
and after.
You can start to see here. It's not there.
You don't have to go back in. You feel satisfied.
I feel really satisfied.
Him being awake allowed us to get that outcome and preserve his function. Now, Andy was back home with his family 2 days after surgery. 5 days after the surgery, he was able to sing at his son's baptism. He's also sang again with his church choir and the Yale Camerata, which is a professional choir, just a couple of weeks ago. Andy is undergoing chemotherapy and radiation, but he does say he's feeling good. And of course, warm wishes to him. He is just
So that is a great example in my mind as to why we do what we do and how we can really push the limits from a surgical perspective. Okay. Another example of a patient of mine who underwent an awake craniotomy. And so this was in another man who presented with language trouble. He was at a different hospital, an outside hospital, and you can see here was his initial scan. He had a glioblastoma just around his language area, and that was prohibiting him from speaking. You can see that he underwent a post-op MRI just a short time after, and really there was not much tumor, if any, that was removed. And so they had achieved a diagnosis of glioblastoma, but he was then referred to me because, as you can imagine, which Zach and Bruce will get to, it can be quite hard to radiate an area such as this or to get patients through chemotherapy when there's that much mass and mass effect and edema, especially near critical language structures. So we ended up getting a functional MRI similar to Andy. We kept him awake during surgery and we were able to remove the tumor, and his language improved considerably. Not all patients need to be awake during surgery in order for us to safely remove and get the maximal extent of resection. This is one of my favorite stories, and I have a lot that are similar, but I think this one really highlights the multidisciplinary effort that we provide on every patient. So this is a gentleman in 2013, as you can see. He presented to another hospital and underwent a biopsy for this tumor that's located here. It turned out to be a glioblastoma. He was told that the mass was too risky to remove. He then was referred to me for consideration of another opinion. I thought that this could be safely removed, and so we did. And even for someone like me who does brain tumor surgery every day, you can still get fooled and you can still miss some tumor. And so this is an example of our intraoperative MRI, which you can see here. That's housed in our operating room, and a little bit of tumor I left behind that got tucked and hidden underneath the brain. So while he was asleep on the table, after I removed most of the mass, we got the intraoperative MRI, saw that, and I went back and was able to resect it. His pathology was confirmed as GBM, showing an unmethylated MGMT status, which is usually a poor prognostic factor. His care was then provided by Joachim Bering, our neuro-oncologist, as well as Ranjit Bindra, who had the patient on our standard of care, stoop, radiation, and temozolomide. Then one of our fantastic homegrown Yale clinical trials that Ranjit was PI and directed and really founded, he was enrolled on. He then was enrolled on other clinical trials that we offer and then switched on various chemotherapies until he progressed. And when he did, Wacom sent him back to me with this recurrence. So I operated on him again. And here you can see we did a wider resection. And of course, pathology was the same, but the whole exome sequencing that we performed that really helps us understand the tumors better showed he had what we call a hypermutated phenotype. And the significance of this is that we know based on the literature that these tumors tend to be more susceptible to immune checkpoint inhibitors. And so he was then started on nivolumab and then also with Avastin intermittently. And he is currently about 8.5 years from his initial time of diagnosis. And I love this story. And when I present it, I always say that this is in no way, and I had resected him one other time. Sorry, I forgot to mention that. I in no way am saying that all of our GBM patients will survive 8.5 years or longer. I really do wish that was the case. But he is a great example of how I believe if he had stopped at just biopsy, there's no way in my mind that he would still be alive 8.5 years after a biopsy. And so this is a great example of how when we work together with aggressive surgery, maximal safe resection, even a few times, we can really push the limits of what we can do with the other clinical trials and other adjuvants. This is a more recent example of a patient who was seen at another hospital in Connecticut. He had this large tumor that you can see here in his fourth ventricle. This actually caused some obstruction of fluid. So at the outside hospital, he underwent a placement of a shunt to address the management and buildup of the fluid, and also underwent a biopsy of the mass. The biopsy showed that it was a malignant tumor, but unfortunately, it wasn't able to characterize what type of a tumor it was. And so this patient was followed with a serial scan a few months later that showed increase in size of the tumor and further backup of fluid despite the shunt. He was referred to me for surgical resection. We were able to remove all of the tumor. And now we can target his treatment better, now knowing exactly what type of tumor it is. And also the shunt was removed because he doesn't need it given the fact that the tumor was removed and the backup of fluid was alleviated. So again, another great example for diagnosis, how it can really be helpful in guiding management. The maximal extent of resection doesn't necessarily apply just to malignant tumors. And so this is an example of a vestibular schwannoma patient, an acoustic neuroma patient. And these tumors are 99.9% benign. And so they're not malignant, but they're tricky in that they occur next to the brainstem, and they have a very intimate association and relationship with the facial nerve. And so this patient presented elsewhere. He underwent a surgery by another surgeon, and this is his preoperative scan. This is his postoperative scan 3 months later in 2012. And you can see not much of a difference between the two. Not much tumor had been removed. They continued to monitor this, and in 2017, in conjunction with another radiation oncologist, ended up giving focused radiation or gamma knife radiosurgery. She went on about a year later to start experiencing this, which is pretty bad swelling in her brainstem. As a result, she became pretty debilitated by this tumor, so much so that she required very, very high dose steroids, which led to a steroid myopathy, which led to significant muscle wasting and weakness. She was confined to a wheelchair. And Zach became involved with her care at that point and kindly referred her to me. When he did, this was her preoperative scan, and that was when he had become involved with her care. You can still see the swelling in the brainstem over here. And we took her to surgery and got a nice resection. So another example where working with people and providing the best possible surgical outcome really does impact people's lives. Another type of brain tumor that everyone usually thinks of as being benign is meningioma. And we at Yale have really done a lot of work to understand these tumors and the biology of these tumors and why sometimes they don't behave as benign as one would think. So this is another patient who in 2015 underwent a resection. I don't have those films, but he had what we call a convexity meningioma. And so another hospital in 2015 underwent resection, was told it was a grade 1 meningioma, not to be worried about it. It was removed and he can go about his life. He ended up having some weakness due to, as you can see, some swelling in 2017 that was associated with regrowth of the tumor. And so he got this scan. He saw a few other surgeons, not me at the time, and the decision was to do gamma knife radiosurgery targeted then. 2 years after the radiosurgery, he progressively worsened. He was confined to a wheelchair with weakness. The tumor had grown more and he had intractable seizures. At that point in 2019, he was sent to me. This was a pretty straightforward surgery despite the radiation, and we were able to gross totally remove it. His weakness improved and his seizures went away. But the question that I have and that we've been asking here at Yale from a research perspective is, could this have been better predicted or managed the first time? And the answer is yes, and I'll show you briefly why. So the Ganell lab, as well as others, has really understood the genomics underlying sporadic meningiomas. And we now know about 80 or 85% of sporadic meningiomas are caused by mutations, somatic mutations in these genes. And so the most common, and in the interest of time, I won't get into everything, but the most common mutation underlying sporadic meningiomas is a somatic mutation involving NF2 with or without chromosome 22 loss. This abnormality has been seen as part of the pathway to more aggressive meningioma formation, and I'll talk about that in a few minutes. And so when we think of grade 1 meningiomas, there's also grade 2 meningiomas, and grade 2 meningiomas can either arise as grade 2 meningiomas, which we call de novo, with certain genomic characteristics, or they can progress from low grade to high grade, very similar to gliomas. Part of the work that I have focused on is the clinical correlations. And so initially, and we've revised this even more so to be more inclusive more recently, is localizing the meningioma subgroups based on genomic mutation with intracranial location. And so I use this all the time in the sense that when patients come to my clinic, based on where their tumor, where their meningioma is located in their head, I can predict with a pretty good degree of certainty the underlying genomic mutation. And so why is that relevant? Because we have gone on, with thanks in part to the Connecticut Brain Tumor Alliance and their support of our work, to understand the clinical relevance. And so these genomic subgroups we have found to be linked to various clinical manifestations, whether that's seizure, whether that's also to do with histological subtypes or bony involvement, etc. We have been able to uncover that. One area I wanted to touch upon, and I apologize for the busy slide, was we were the first to publish on recurrence being related to meningioma molecular subgroup. And so again, very busy slide, but the take-home message is that we identified 4 of the genomic subgroups with more aggressive clinical behavior in terms of recurrence. And so specifically those tumors with an NF2 mutation, those with an AKT1 mutation or other molecules involving the PI3 kinase signaling pathway, hedgehog signaling pathway, or TRAF7, were more likely to recur at an average 22 times higher than others. And this held true at 17 times higher amongst grade 1s. And so what type of mutation is underlying or driving the meningioma biology is associated with whether or not the tumor will recur, and even when it will recur, in that some of these tumors with AKT1 mutations in the PI3 kinase signaling pathway typically recur sooner. And this is one aspect of the answer to the puzzle as to why some grade 1 meningiomas behave more aggressively. And so here, going back to our patient, how could this have been predicted and managed differently the first time? This is how. And so this is an example of our molecular analysis report that we receive on every patient we operate on at Yale. And here, the histological diagnosis of this patient was actually a grade 2 meningioma, not a grade 1 meningioma, which was initially diagnosed in 2015. So you might say, well, maybe it transitioned from a low grade to high grade. The answer is no. looking at the molecular information, there's an NF2 mutation, and then based on the chromosomal abnormalities and the copy number alterations, we can tell that this was one that was de novo and had been atypical meningioma, but was misdiagnosed histologically back in 2015. And so in our hands, we would have resected that tumor and likely radiated the tumor upfront after, or at least kept a very close follow-up. Another patient with another one of these grade 1 meningiomas, this was a patient that was operated on by someone else, had this large tumor. Surgeon left a small residual to preserve endocrine function, and just 6 months later, you can see the growth. That's not growth that you would expect with a grade 1 meningioma. And so then the patient underwent radiation and then continued to have growth. This is actually not the most recent follow-up. I'm sorry for that error. She's had more growth, more recurrence, and I've operated on her a couple of times since then. She's had more radiation and has been enrolled in clinical trials. And here's her histology and molecular report. So it still remained a grade 1 meningioma, but you can see that AKT1 missense mutation. And based on our findings in the Neuro-oncology paper, and here you see that these tumors tend to occur earlier. And a last patient example, a very complicated patient with another grade 1 meningioma who underwent surgery elsewhere a few times, radiation elsewhere a few times, was enrolled in a clinical trial with Priscilla Brastianos at MGH. She recurred. This was her recurrence, a highly vascular tumor, as you can see. Priscilla sent her down here to me for surgical resection. We got a nice surgical resection, and here's her genomics, again, that AKT1 mutation. And so the point being is that maximizing the surgical resection is, of course, a huge part in survival and progression-free survival. Getting a good tissue diagnosis is incredibly important, but really managing patients as we do, and most academic centers do, based on the molecular diagnosis and not just relying on histology is incredibly important. We hope that our patients find it easy to navigate through the system, through our multidisciplines, and of course through our health system, including Bruce and others who are located in Greenwich and other satellite places throughout the state. We're so thankful to the Lovemark Foundation and the Connecticut Brain Tumor Alliance who provide support to our patients. And I am incredibly thankful to these ladies and men who I work with every day, Jillian and Marcy, who are nurse practitioners in our brain tumor surgery program, Kelly and Marcia, who are our nurse coordinators, Larry and the other staff who work in the operating room who assist me every day, my clinical research fellows, Sagar Shari, and a bunch of other people who unfortunately aren't in this picture, and Neelan Marianayatham, my clinical fellow. So thank you once again for listening. Thank you to Dr. Beris for her generosity and her friendship. And I will turn this over to Zach. And I guess we'll take questions at the end, and I'll stop sharing. So Zach Corbin, a friend, a colleague, a wonderful neuro-oncologist, and I'm really excited because he's going to speak to you now about emerging therapies for brain tumors, and he's also going to talk about some of his exciting research and work that he's doing with imaging.
Perfect. Thank you so much for that wonderful introduction and talk. And what a lovely dovetail. I wish if I had actually been able to modify my title, I would say emerging classifications and therapies of brain tumors, because a lot of what I'm going to talk about is exactly that. We have changed recently the way we're thinking about primary brain tumors. So, so I'm Zachary Corbin. I'm one of the neuro-oncologists based at Smilo, and I look forward to talking to you for a few minutes today. And thank you for having me. So I'd like to start by saying that I do have a disclosure that I will be discussing off-label use of procarbazine, otherwise no relevant disclosures. I'm going to talk about the structure of my talk. I'm going to talk about glioma and meningioma, very similarly to Dr. Moliterno. Talk about the classification that we have begun to use very recently based on the 2021 WHO, and then standards of care, including some relatively new ASCO/SNO guidelines that can help clinicians make the decision about patients' who are not able to or choose not to enroll in clinical trials. And then, of course, I want to discuss about clinical trials that we have available at Yale and the approaches that they may offer. Then I'll switch to meningioma. And Dr. Moliterno has covered a lot of the standard of care of meningiomas already, but I'll summarize. And then I'll discuss a couple clinical trials we have available. And absolutely, at the end, I look forward to sharing some research that I'm doing and some observational studies that are available to patients who are seen at our cancer center. So without further ado, I'd like to talk a little bit about glioma. And I'm sure most people watching this talk are familiar with the disease, but some, I think, underappreciated facts include that it is the second most common type of primary brain tumor. It has a higher burden than I think most realize, at 19,000 new diagnoses in the US, the most recent count annually, and over 12,000 of these patients have glioblastomas. And despite even more than what Dr. Moliterno has had a chance to cover, what we do clinically and research, despite all of this and for decades, just a little bit over 1 in 20 patients at 5 years remain alive. The most recent count is 7.2%. And I'm going to end by saying the silver lining is that count is going up. And so we are making gains, and we are continuing on our quest, as I'm sure most watching this talk are. Pathologically or histopathologically, and hopefully you guys can see my pointer, glioblastoma appears like this. You can see lots of areas in the tumor microscopically that have different shaped nuclei. You can see necrosis, you can see pseudopalisading areas, which is what this is called, where you can see the sheets kind of dive into the necrosis. You can see areas of vascular proliferation. Another thing that I always like to talk about is how important publicly this disease is. So these 3 men all died of glioblastoma or high-grade glioma. And for those of you who don't know who one of these people are, I'm sure that most people know all of them. This is Ted Kennedy. He was President John F. Kennedy's brother. This is Beau Biden, President Biden's son. And this is John McCain, most recent example in this picture. But I think that this really goes to show how, although a rare disease officially, an extremely important disease in many other ways than we might initially think. So as I said, I'm going to talk about the way we classify gliomas in the context of the 2021 WHO classification of tumors of the central nervous system. This is actually very recent, and last time I checked, we still didn't have the, because of COVID-related printing delays, we still didn't have the actual final results to review ourselves, but we have this preview, and I'm going to summarize it for you today. So the preview, I think, is best summarized in a diagram, and you can see starting here that really we start where we used to be with histopathology, and then as Dr. Moliterno was discussing, the answer is largely now related to molecular findings. And the first dichotomy is the IDH, isocitrate dehydrogenase genes. So a tumor that expresses an IDH mutation is a tumor for which we understand the patient who has that tumor, their outcomes are better and the tumor grows less. And then a dichotomy after IDH mutation is whether or not that tumor expresses another genetic change that's called 1p19q co-deletion. And so an IDH mutant 1p19q co-deleted tumor, almost no matter what it appears under the microscope, is an oligodendroglioma. And oligodendrogliomas are actually graded histologically, as are the other tumors. So that is where we can use histology and molecular features. So WHO grade 2 and WHO grade 3 oligodendrogliomas. And then if actually there is no 1p19q co-deletion, you can see that there are astrocytomas, which are IDH mutant. These are kind of cousins of glioblastoma, but actually even a grade 4 astrocytoma that is an IDH mutant is in this classification not considered a glioblastoma. That is a big change. We used to call patients who had tumors that were WHO grade 4 histologically a glioblastoma if they were astrocytic, whether or not they had IDH mutations. So you can see that this whole category of tumors is quite different because it has different molecular features and also different clinical outcomes. And so moving right, unfortunately, these tumors grow more aggressively. Patients who have them have generally shorter outcomes, although with aggressive treatments, we're hoping that that also will change. So if a patient does not have an IDH mutation, we refer to that as an IDH wild type tumor. And you can see that those characteristics under the microscope I described before can help describe a glioblastoma, which is also called glioblastoma IDH wild type, CNS WHO grade 4. And then you can see that there are other similar glioblastomas or similar gliomas, that have a grade 4 characteristic. And in general, these are considered diffuse midline and diffuse hemispheric gliomas, with the midline glioma has an H3K27 alteration. So moving on, the standard of care for glioblastoma is still based on a study that was actually old when I was a fellow, which is the Stoop protocol. And you'll hear us discuss the Stoop protocol when we discuss management. And a couple things I want to highlight on this slide is that the curves, despite aggressive treatment, continue to go down, but this is actually continues to be the basis for which we treat many patients, and maybe motivation to keep these curves up for pursuing more clinical trials. And then the other thing I'd like to show, once again, is that it's 2005. So now 17 years old, and we do have additional advancements. I'm not trying to say that we have been frozen since 2005, but it is remarkable to think about how long we've had these results. So as I was saying, I'd like to move forward to discuss guidelines, not just how to treat glioblastoma, but all gliomas. And so this is the American Society for Clinical Oncology, ASCO, and the Society for Neuro-oncology, two American organizations to manage neuro-onc. And they issued combined recommendations for the different categories of tumor. And so I thought I would just go through the different categories one by one. I mentioned all of these in the diagram that I discussed before. Oligodendrogliomas, WHO grade 1. I should say, but you guys already know, maximum safe resection and when possible is the start to management of almost all of these tumors. But once we get to maximum safe resection and have the best pathologic evidence, observation is possible, which means we monitor closely with scans in these patients. Low risk disease has specific features, but if a patient is over 40 or a patient has remaining tumor, they are not considered low risk. And so we proceed with radiation combined with either procarbazine, lomustine, and vincristine, which you'll hear me discuss for here on as PCV, or Timidar, or TMZ. Timidar is emphasized as an option if there's concerns for someone tolerating PCV. However, I would say that there are also oncologists that actually favor Timidar because the evidence is also strong for Timidar in that the Stoop protocol, for example, is treated a more aggressive tumor with Timidar. And this is an open question, which we are actually trying to address at Yale. Oligodendrogliomas, WHO grade 3, we do not have any ability to monitor these, whether or not the tumor is entirely, or we would not recommend, I should say, monitoring these, whether or not the tumor is entirely removed. We would proceed with radiation combined with PCV, or possibly using Timidar as an alternative. Astrocytomas IDH mutants that are WHO grade 2. For those of you who are familiar with the old classification, these used to be called diffuse astrocytomas. These are possible to observe, once again, with good characteristics. Some would argue that they should be treated with radiation followed by adjuvant chemotherapy. And in this case, I think the field generally prefers Timidar over PCV, but the guidelines offer a choice between both. In case it's not clear why one would prefer Timidar over PCV, PCV is a chemotherapy regimen that involves multiple chemotherapies that each involve different side effects that can be difficult to tolerate, and they can also limit the ability for the patient to take the whole regimen. Timidar is less prone to those limitations. So moving forward, astrocytoma IDH mutant WHO grade 3. This is a tumor that there is some debate about how to treat, but radiation with adjuvant Timidar is the recommended method in the guidelines. And then maybe there's more debate with IDH mutant tumors, WHO grade 4. Once again, these tumors used to be called glioblastomas, but we now refer to them as astrocytoma IDH mutant. So radiation with adjuvant Timodar is offered, or treatment per the Stupp protocol as glioblastoma is treated. So moving forward, glioblastoma, IDH wild type tumors, astrocytoma, IDH wild types, either grades 2 or 3, are generally recommended to be treated as glioblastomas. Glioblastomas are IDH wild type, WHO grade 4. So those tumors we recommend treating either with the Stupp protocol or possibly additional changes in a subset of patients. So the Stupp protocol, which I've now mentioned probably 8 times by name, but haven't actually told you what it is. This is where you do radiation combined with Timodar at the same time. That's called chemoradiotherapy with Timodar. And then patients receive 6 cycles or 6 months of Timodar thereafter. Patients are certainly, or physicians and patients together are certainly allowed to receive more chemotherapy. Up to 12 is still standard, but most of the field is considering moving back to 6 cycles at this point, certainly in some patients. And alternating electric fields are delivered by a device called the Optune device. And this may be added either actually at diagnosis, which is what this recommendation is about, or at recurrence actually. In a subset of patients, these patients are patients who may be elderly or may have some reasons why we don't think they could tolerate what ends up being quite an intense therapy. We can proceed with hypofractionated radiation with concurrent and adjuvant Timodar. Hypofractionated is only 3 weeks long as opposed to 6 weeks long, but I'm not going to get into any more details about radiation because Dr. McGibbon is the expert and will be speaking later. And then alternatively, if we think that Timodar may not be useful because of other molecular features which are outside of the scope of this talk, you could do hypofractionated radiation alone. You could do Timodar monotherapy alone. And then, of course, there are some patients that either choose or may not tolerate any treatment, and supportive care is an option to proceed with glioblastoma. So on a brighter note, I'd like to talk about clinical trials that we offer. So one thing to talk about clinical trials is that these trials often don't replace the standard of care. We get that question a lot. Often they will augment the standard of care, or they ask questions about the standard of care. And the other thing to note about clinical trials is that a clinical trial that I would recommend to a patient is going to be one that exhibits equipoise. This is a true experiment where we're trying to answer something we don't know the answer to. And so I mentioned the question that this trial is trying to address already. So we have a trial for patients who have oligodendrogliomas, WHO grade 2, who have high-risk disease. Once again, they're over 40 or they have a residual tumor, or grade 3. They can enroll in a trial where we are actually proceeding with adjuvant radiation that's either combined with Timodar, or they proceed with radiation followed by PCV. Because once again, we have this question where we don't know what is better in oligodendroglioma in patients who have oligodendrogliomas. We have more trials in patients who have glioblastoma. So we have a phase 01 trial, which is an early phase trial, where we're testing an immunotherapy regimen that targets a type of checkpoint that's called TIGIT, that is used in addition to, or possibly alternating with, the PD-1 checkpoint, which is a more famous checkpoint that others may have heard of. Drugs like pembrolizumab and nivolumab target the PD-1 checkpoint. We have a phase 1 trial of a drug called FBPMT, which is targeting cancer cell signaling. And that is for patients who have glioblastoma at recurrence or when the tumor is growing back, as Dr. Moliterno showed in multiple of the cases. And then we have a trial that's really complex and really kind of marvelous. It's called the GBM Agile trial. And this trial was designed to exist for a long time at a brain tumor center like Yale and allow us to sub in. It's called Agile because we're able to sub in drugs that may be exciting without having to close the trial and open a new trial. And so we have multiple arms in this trial, so patients can receive multiple types of therapies. And also the trial allows for enrollment of patients in different phases of their disease. So there are GBM Agile arms where patients can enroll at diagnosis and where patients can enroll at recurrence. So it's complex to describe, but really an amazing thing and a pretty remarkable advance, I think, in clinical trial design. And it's a privilege to be able to offer patients the agents that are being tested in GBM Agile, and they will continue to change over time. We also have a phase 3 double-blind placebo-controlled trial where we are adding, as I said, we often adding a experimental agent called enzastarin to the Stupp protocol. So to shift gears now, so I'm going to talk about meningioma briefly and then some trials we have in meningioma. Meningioma is actually the most common type of primary brain tumor. Its annual incidence is around 35,000, which I also think is remarkable. And as Dr. Moliterno covered, many patients who have meningioma are patients who have benign meningiomas, although I would prefer to call them meningioma WHO grade 1. That's what we label them pathologically. That's about 80%. And the overall survival of these tumors is difficult to categorize and has been reported in different ways over multiple sources, but I'm giving you summaries here. So patients who have WHO grade 1 tumors certainly live over 10 years, and they may live longer. Patients often don't even need surgery with these tumors, and so we don't actually really know the true burden of WHO grade 1 meningiomas. But about 18% or about a fifth of patients have more aggressive tumors that Dr. Moliterno has lots of experience with, called atypical meningiomas, WHO grade 2. And there's variable reports about how long patients in general live at this point with these tumors, but we think about 80 to 100% of patients remain alive at 5 years, which is good. Unfortunately, WHO grade 3 tumors, also called anaplastic meningiomas, I guess fortunately they're quite rare. Approximately 2% or so of patients have these tumors who have meningioma, but the median overall survival is much more dramatically lower, at measured in a couple years, 2 to 3. So standard of care with meningioma. So we have to discuss something that we don't generally talk about in gliomas, which is presumed meningiomas. There's a whole category of patients who have a scan. I think sometimes they get very scared. They come to see either a neurosurgeon or neuro-oncologist, and we may tell them, this tumor may not cause you difficulty. It looks to us like it may be a WHO grade 1 meningioma, and we can monitor it. And so we call those presumed meningiomas. They're often asymptomatic, and imaging surveillance may be appropriate. But once they become symptomatic, which often they do, and then I might refer that patient to Dr. Moliterno, then we proceed with maximum surgery, just the same way with glioma. And surgery or radiation, if surgery is not possible, are the options for these presumed or asymptomatic meningiomas. And really, as I was saying, with all grades 1, 2, and 3, we start otherwise with maximum surgical resection. Meningioma WHO grade 1 specifically, if it has recurrent disease, we consider radiation. And then we get into controversy, which we are having also a clinical trial at Yale to address. So the controversy is what to do with someone who has an atypical meningioma WHO grade 2 that has had a gross total resection. As Dr. Moliterno showed in a case, these do recur, but not all the time. And sometimes we think that the radiation may not actually benefit as much as it causes some patients harm. So we then proceed to more specific cases where there is residual disease on the scan after a surgery. And for those patients, we do recommend radiation. For patients who have anaplastic meningioma, there's even less controversy. For those patients, resection or otherwise, we recommend radiation. So the clinical trials that are available in meningioma, for WHO grade 2, after gross total resections, this controversy is addressed by a phase 3 trial, where it's randomized. Patients either go on surveillance or we proceed with radiation and we continue to monitor. For patients who have either WHO grades 1, 2, or 3, any of those grades, if they have a specific target, they are offered enrollment in it's a multi-arm trial as well that currently has an AKT inhibitor that's called capivasertib, or a CDK inhibitor that's called abemaciclib. Abemaciclib is actually currently an approved medication, and so it's interesting to be able to offer it in this trial. So now I'm going to switch gears and talk about one of my true loves, which is measuring metabolic disease and also metabolic processes in primary brain tumors. And I'd like to talk briefly about what target you would do, or what metabolic change you would measure. So that is called the Warburg effect. The Warburg effect is really a biochemical principle, and really briefly, when any cell, this is the outside of the cell in my diagram, this is the inside of the cell, calls glucose, which most people are familiar with. You eat, you get glucose. Glucose comes in, it becomes a certain molecule called pyruvate, and then the body may process it either through a process called oxidative phosphorylation, through a part of the cell called the mitochondria, which is this is my cartoon, and then it evolves CO2, which might be bicarbonate, because bicarbonate and CO2 exist in water, which most of the inside of the cell is. Alternatively, pyruvate may become lactate, but it actually does not use oxygen in this case, and that's called glycolysis. So the Warburg effect defines the fact that even in normal oxygen, a tumor cell or tumor process favors lactate and glycolysis. And so that Warburg effect shifts tumor physiology in this diagram to the right. And so to measure this difference might help us with lots of insights about how tumors work. And I have two ways that I've opened observational studies. These are not trials. We're actually just trying to measure characteristics of the tumors and not affect anyone's care. But two ways we might measure the Warburg effect. This is called the Warburg Index. We take patients and offer them what's called an FDG, or fluorodeoxyglucose PET scan. So FDG is a small dose of radioactivity that also comes via the blood, comes into the cell, and it's phosphorylated, or phosphorus is added to FDG, and it stays there, and we can actually observe it in something called a scintillator. Now, the very observant ones would say that we're only watching one part of metabolism. That's right. So this is actually basically total glucose metabolism. This is a rough estimate of oxidative phosphorylation. So we use a different technique in these patients as well, called MR spectroscopy, or MR spectroscopic imaging, and we can detect the lactate. And so we have both sides, lactate and FDG, will give us the Warburg Index. This is a clinically available tool, and we're very excited to be able to offer it to patients who are otherwise receiving care at our brain tumor center. And earlier, but also very exciting in its development process, is called deuterium metabolic imaging. Deuterium metabolic imaging, we use deuterated glucose that patients can just drink, same way you drink a soda or a Gatorade. And the glucose comes in, it becomes pyruvate, it becomes lactate, and it becomes molecules called glutamate and glutamine. The point is that in a marvelous way, in this specific MRI scanner, we can actually see lactate and we can see glutamate and glutamine representing these two processes directly. And so we can see the Warburg Index shifting to the right, and we call this the Warburg effect once again. And so here's a great example that we were able to publish of a patient of mine who had a brain tumor, and this is actually an IDH wild type glioblastoma. And you can see that they have a very large Warburg effect. So there's lots of possibilities here about what we might use this for. Patients who have higher Warburg effects, we have a theory that, and it has been shown, their tumors are more aggressive. And can we actually watch the way the Warburg effect might change over the course of their treatment, either in radiation or chemotherapy? Can we predict whether or not someone might survive the way the patient with the tumor that Dr. Moliterno showed? Can we predict better survival or poorer survival based on metabolic signatures? So thank you guys so much for listening. I want to acknowledge all of my current and prior lab mates, and they have done so well. 2 of them are already in medical school, and also my funding. I received a YCCI Scholar Award, as well as my collaborators R01. And this is really a process, both clinical care for brain tumors, as well as clinical research for brain tumors. It takes a village. And not only Dr. Moliterno and the other neurosurgeons, not only Doctors Bering and Omoro and Hafler and the other neurologists, of course, my mentors from before, the YCCI, my colleagues at MRC, the PET Center, and of course, radiation oncology, including Dr. McGibbon. So thanks so much, everyone. And I will now stop sharing so that everyone can move forward. I guess we'll take questions at the end.
Yeah, people can just throw questions into question and answer or into the chat, but that was really an excellent talk, Zach. Thank you so much. So next, I just want to introduce Dr. Bruce McGibbon, who is from Greenwich Hospital. He is the medical director there for radiation oncology.
Thank you so much. Great talks so far. I'm really pleased to be invited to give this talk. Like Jen was mentioning, I'm down at the Greenwich site, previously at the Trumbull site, and it's just really great to be able to collaborate with our experts in New Haven and extend care down the state to really have a broader outreach to what we can help patients with this type of collaborative care. Let me share my screen here. Go back. Okay, so I'll be talking about the role of radiation therapy in the treatment of brain tumors, and with a particular focus on glioblastoma and meningioma. I have no disclosures. So where does radiation therapy fit in? You've heard about it a little bit this evening, but just briefly, I'd say for benign tumors, sometimes radiation is given in place of surgery if it's something quite small and really doesn't require surgery, but more often given sometimes as post-operative treatment if a tumor is left behind or we're somehow extra worried that it will progress. And then for malignant tumors, we've been talking about glioblastoma and the anaplastic tumors and so on, that Dr. Corbin was doing such a nice job of going through. Sometimes we'll offer radiation when there's only been a biopsy, but more commonly, as we've heard a lot about, we really love when a maximum safe resection can be done, and the outcomes are so much better. And we really are hand in glove with all the other experts from neuro-oncology, surgery, and the other folks being mentioned on this talk series. For radiation, most of the treatments are done on what's called a linear accelerator, which is what we see in the top left corner here. And I'll use the cursor. So a patient would lie on the table like this, kind of zooming in. There's usually a mask that's done to help hold people still. It's not painful in any way. You can see and breathe through it, but it helps to hold the head still. So when we're delivering radiation with millimeter or sometimes sub-millimeter accuracy, we're really delivering it exactly where we want and not a little to one side or the other. The radiation comes out of the head of the machine here, and this portion of the machine can rotate around, so we can come at the tumor from different angles. In the head of the machine is a really nifty device called a multi-leaf collimator, which is represented here. Each of these, you can all see they're almost like little slats, and these are very thin leaves. They're very tall, but they're made of a tungsten alloy, which is a really heavy metal. And when patients often ask, when I go to the dentist, I have a lead apron, what do I get here? I say, well, the lead apron's not going to cut it for therapeutic radiation, it'll go straight through it. But if you have the equivalent of a lead apron, which is several inches thick in the head of the machine, that's what's really giving the protection and doing the shaping of the radiation. We also have something that's been developed over the last, I'd say 10 to 15 years, and is really hitting its stride now, called image-guided radiation therapy. So we do some planning scans before radiation, including a CAT scan, and overlay that, as I'll show later in the talk, with MRI studies and other studies that will help us to show where we want to treat and what we want to avoid. And then when the patients come for these daily treatments, we can do imaging on the table. So if you look here on the right, the head of the machine here, again, is where the radiation comes out. But these panels on the sides can do imaging. So we can look in the head and say, okay, how does the skull align today compared to yesterday, compared to when we did the planning scan? And so these images on the left and the middle are representing really a fusion or overlay between a daily scan and a planning scan. Just give one example here of a glioblastoma. The patient presented with headaches and some difficulties with concentrating. And the image showed this large tumor on the left side. I'll just go briefly through this because it's already been discussed very nicely by Dr. Corbin, but for glioblastoma, we're always looking for that maximum safe resection. We usually allow about 3 to 5 or up to 3 to 6 weeks between surgery and when we start the chemotherapy and radiation, and then to be followed by more chemo and sometimes that Optune device. When we're making a decision about what style of radiation to use, we're looking at the age, the overall performance status, other features like MGMT that was mentioned a little bit before. We're looking to see if there are any clinical trials that are available to really try to advance the field in that way as well, and give patients the best that's possible. So we put all that together and see which style of radiation we're going to do. I would say the majority of the time we'll use that Stoop protocol with 30 treatments. Actually, these are done Monday to Friday. So it's a 6-week course. It actually has 2 phases, the first 23 treatments and the final 7, where the first 23 are a little bit broader and the final 7 are a little bit smaller. They call it a cone down idea. And that's the most common one by far. But we have what's called hypofractionated treatments, and those could be offered in someone who's elderly and has some other performance issues, or there's a travel concern, or things of that nature. We're trying to be creative in how we're going to deliver the treatment and balance side effects with treatment intensity and intent. So in the hyperfractionated realm, the one that we use the most is a 15 treatment course, but we have actually data for 5 and 10 treatments. Usually if we're going all the way down to 5, those are pretty intensive. So that's usually in somewhere we're not doing a chemotherapy. And I would say probably the same with the 10, but 15 can be done with or without chemo. So going back to the case, we have this glioblastoma where now things have been removed. We get a post-operative MRI to assess what that looks like now. And then we get into the planning phase. So what we'll do is we'll take where things were before surgery and where they are after surgery and do some drawings, which are represented by this kind of teal color or cyan color and the purplish pink color. And we're trying to really dial in what we need to treat. And this could involve collaboration with the surgeon as well. If we're not sure about one area, talking to the radiologist, so we're really dialing in what's at risk here and creating a margin around that to account for any microscopic extension that could have happened. There's a very intensive design process where we work with our physics crew. Typically between the time that we got our planning CAT scan and make that mask and when we start treatment is about 1 week, sometimes up to a week and a half. It's a more complicated case. And these images on the left are representing, kind of vaguely make out that there's also a person's head that's represented in this treatment planning software. And again, those kind of pink and bluish colors are representing what we're trying to treat. And usually these treatments are done in arcs. So this picture on the bottom is trying to represent how the machine is going to move around the head. So at each, we can play with different things. We can move the angle of the table to create a different angle of attack. We can move the gantry or the head of the machine around. And at every position, we can vary the intensity of the beam and the shape of the beam. And ultimately, that allows us to create what we call a dose distribution, which you're seeing here, where we are trying to conform the higher dose region of the radiation to what we're trying to treat and then have it drop off away. So in this case, on the right, we're trying to, these images are done as if you're looking at someone from their feet towards their head. So this kind of right side of the image is actually the left side of the body and vice versa. So in this case, we're really trying to avoid radiation dose, especially going to the right side of the brain. We go through an intensive process where when we design the fields, we get this complicated graph called a dose volume histogram, where every color here represents a different structure that we're trying to either treat or avoid. And so there's this iterative process with the physics crew saying, okay, this plan looks good, or no, we need to shape the doses a little bit more to stay off the brainstem or off the cochlea or whatever it might be. So we look at these and ultimately sign off on one that looks like the best balance. Moving to meningioma, is a real great statement from the National Comprehensive Cancer Network saying, I'll just read it here, treatment selection should be based on assessment of a variety of interrelated factors, including patient features, tumor features, potential for causing neurologic consequences if untreated, presence and severity of symptoms, and treatment-related factors. And I'll skip to the bottom. Multidisciplinary input for treatment planning is recommended. And this is where I feel so blessed to be, part of this Yale network, is really having these super skilled, trusted colleagues where we have these weekly conferences and we can call each other at any time and get advice on a case or have someone seen. And it's just really critical to have that. And nice to see it represented as the the goal according to national guidelines as well. So meningiomas, again, touched on in a lot better detail and more thorough detail with Dr. Corbin, but just it's kind of a very quick overview again. Sometimes we can do just observation if these are small grade 1 tumors, but if they're getting more advanced, then we typically will do surgery. And if it's a grade 1, it's usually just observation or sometimes radiation if there's a further issue that we should be considering. Grade 2, I'd say most often do radiation. especially if there's a little tumor left behind. And for grade 3, we definitely offer radiation. Radiation in this case is a little shorter than glioblastoma. It can be up to 30 treatments like glioblastoma, sometimes a little less, but the dose per day is a little bit lower. And it's usually done as this Monday to Friday course. Sometimes, especially if it's being done for a very small tumor and it's lower grade, we can do what's called stereotactic radiosurgery, where it's only 1 treatment or up to 5 treatments. But I'd say a lot of what we do is the multi-treatment option. And again, I think that just a short case presentation is really helpful. So this was a patient who presented with double vision, followed by a right eye decreased vision. And you can see in the scan with the red arrow, there's something that really doesn't belong there. And if you look here, here's the eyeball, and you see this darker gray coming back. That's the optic nerve, bringing the visual information coming back. So this tumor is really not only near some really important blood vessels, but is also near the super important nerve. So what to do? Radiation alone is really not going to be her best option. Radiation is excellent. I'd say it's stopping meningiomas from growing further and can make them slowly regress, at least sometimes given enough time, but it's really not going to create a rapid shrinkage. It's not what we want. Someone's having these kind of symptoms like double vision, things we need something more quickly effective, and that's really comes down to surgery. So this lady underwent a right-sided craniotomy with Dr. Moliterno, and because of that location there, next to what's called the cavernous sinus, where some of the special blood vessels are, it's really not possible to fully remove the tumor, but a lot of it was removed. It turned out to be a WHO grade 1, and she had a great response. Her vision came back to 20/20, and had, I would say, a near resolution of the double vision that ultimately fully resolved. So we got a post-operative MRI, and as expected, there was a little bit of residual, but much better, as reflected by her symptoms as well. So you see the pre-op on the left and post-op on the right. And of course, we don't want this growing back, and so we offered radiation. Similar idea in terms of the mask and so on, using arcs, again here, working with the physics crew to design a set of radiation fields. If you look behind here, this is where the brainstem is, so we're trying to stay off that and off the eyeball, so we're able to create this really, as we say, conformal radiation technique. And the combination of the surgery and then the radiation was able to really permanently control this tumor. Just a quick, also shout out to my colleagues and Dr. Bindra here, just to further emphasize what Dr. Moliterno and Dr. Corbin said. There's really great and super detailed work that's going on with all these different mutations and adults and kids, and it's just a lot of work to be done, and it's just really impressive. There's just one trial here working on with malignant gliomas, and that Dr. Bindra had shared with me. Just click through, and then another one looking at adolescents and young adults, another tricky glioma case where there's more work to be done, and really great collaborations happening. And thank you very much. I'd be happy to answer any questions later.
That was really an outstanding talk. Thank you, Bruce. And there was already one question. We want to take it now or later, but it was about how cyberknife radiation fits in. And I think that was with regards to glioma. So you can start thinking about that answer.
No problem.
You know well.
Yeah.
And then also what actually is the radiation as compared to an X-ray or dental X-ray? So that's another radiation question coming your way.
Very good.
So we will conclude with Brian Jin, who is the licensed social worker who leads our brain tumor support group, along with our team, Jillian Bungard, who is on as well. And he's going to talk about probably even more important than surgery or radiation or chemotherapy, but how we can support our patients and their families.
Hello, everyone. Thank you for that introduction. I have the privilege of facilitating the brain tumor support group with Jillian, and they have taught me a lot, and I think about them a lot as I'm doing this presentation. So I'll go ahead and bring up my slides. So I'm Brian Jin. I'm one of the clinical social workers at Smilo Trumbull. I work with primarily Dr. Lin, and I have the privilege of facilitating the support group. So my role is primarily supporting patients and family, both emotionally and also helping them navigate the system, find resources within the community, and it looks different for everybody. So it really depends on what families and individuals bring to the table prior to diagnosis. Every family system is extremely complex. They bring different compositions, they have different roles, different stages of life. They have different pre-existing diagnoses that might impact how they respond, maladaptive behaviors that help them cope at one point, but not now. So really identify the work and where we can help. So this PowerPoint is on the framework that helps me navigate and support people. And also I'll go through some of the primary challenges that people experience with a brain tumor. And then I will go into ways that Smilo and the community supports patients and families. So one of the frameworks I use to help me sort of identify and navigate and identify the work is by Dr. Wallen, Family System Illness Model. And how it's useful is it really takes the whole family into account. It really spends time looking at the system and incorporating the medical team within it, looking at the various ways that families interact and support each other, what strengths they have, what do they bring culturally. It's a very broad and very fluid model to use. And then it breaks down the work, both the emotional aspects and dimensions, the concrete basic needs that need to be addressed, and also how these interplays work with each other. And then it takes it within each phase of time. What initially we experienced during that first diagnosis period, what it looks like when we become stable and we found a period of equilibrium. And then anytime we experience a need to change, a need to adapt to a new struggle or limitation. So this is one of the ways it is extremely useful for supporting families. So the crisis phase, this is the most difficult time. This is like being shot out of a cannon. Oftentimes I've sat and heard the stories of being diagnosed and being in the car and suddenly having a seizure and then waking up post-surgery, and how they adapt to that, how they absorb that information that's coming at them, how their family is responding to suddenly maybe the primary breadwinner not being able to work. What do you do at that time? There's so many questions. There's so many unknowns and fears that are arising at that time. One of the things that is a challenge is that they have to absorb this new information about the diagnosis that they would never have assumed they would encounter. They have to understand medically. They have to understand how it's impacting their whole family system emotionally. They have to understand it in the short term and then the long term. What is my plan? What is my treatment options? And that is one of the things that helps people cope. Having a really grounded and supportive plan and being connected to medical providers that can guide them through. So these challenges, as they arise, they take a lot out of the family. They engender a lot of uncertainty. And one of the roles that I have to support people with is identifying their strengths, identifying their sense of faith, what narratives they're using, their family resiliency, legacies that they have within themselves that have helped them through adversity. And we're looking for stabilization. We're looking for a place for the difficult emotions, a place for identifying what they feel at the moment, whether it be anxiety or feeling overwhelmed or shocked, and then gradually lessening those, giving those a chance to sort of dissolve and have their moment, but then move towards the positive side and what is their course of action. One of the big emotional things that tends to come up that I see and oftentimes isn't always identified is grief. A lot of times families are in the state of shock and they've lost something. They've even lost the ability to look at life as this is stable, this is known, this is safe. I've had a family member say, I'm angry just looking at that family go into the diner because their life is so mundane. It's so normal. And now we're suddenly thrown into a state of shock. These are really the challenges of the initial phase, is recalibrating, finding order, finding mastery, finding competency, and trusting in their plan and collaborating with their medical providers. The next phase is titled the chronic phase. And this is the phase I wish the support group could be here to share, because they're the ones who should give the master lesson. And it's a difficult phase. It has its own unique challenges. One of the ones that universally I hear is living with uncertainty. And any person who has had to go through a scan and wait for the results knows what that feels like. It holds all the hopes, all the fears at the same time. And this is a really difficult thing to manage. It produces a lot of anxiety, a lot of worry, and a lot of questions that arise from that. And the tendency is to project towards the future, sometimes catastrophize. And so it can be a very challenging emotional process to address. But it's something that's going to be universally have to be managed. And, the support group is one of the ways that we manage it. You get everybody coming together to share how they cope, everyone sharing the ways they managed it. And a lot of it is really, for me, this is about being present in the moment, connecting with what is good, connecting with makes you happy. That relationship with the providers, that's also there. Sometimes you're going through all these treatments, and I've had patients say, I want a week off so I can go to a wedding or a graduation. And this is part of that responsibility, and where the rapport becomes so important. And another part that my support group shared with me is knowing your new limitations and how do you transcend them? What do you have to be sensitive to? What can you do? What can you have to modify? And finding that new balance in life, which is a lot of work. And the final phase is transitions. Anytime we have to find a new way of adapting, if we're meeting a new struggle, a new challenge, that's the stage of change. And that requires recalibration. Again, maybe not as shocking, sometimes it is, but there's different work to be done. Sometimes this phase really hones in on what is our priorities, what is the most important thing for us to do. And it has its own special nuance. So from there, using this framework, there's different things to address. Sometimes in that beginning, it's a question of how do I meet? The world doesn't stop. Unfortunately, we have to pay bills. We have to bring the kids to school. It depends on everybody's stage of life and where they are and who they're responsible for. And so one of the questions I often get is like, how do I find the balance of making ends meet and prioritizing my health, which is now my job? Questions about disability, whether or not you have short or long-term disability, applying for a Social Security disability. Nobody gives us this information out in school or college or anywhere. So these are one of the things you can access through your team, through your social worker. You can ask your team if you need assistance and help. There are resources out in the community, including the Connecticut Bureau of Rehabilitation, which will help people re-engage in a new profession or work with accommodations. Your team can also be a source of referrals to occupational health, things that get you back on your feet, making you operate a little bit better. One of the big things for me is maintaining health insurance, because anytime we have a shift from disability, from employment, there's concerns about maintaining health insurance. There are COBRA, there is Medicaid, there's the Access Health CT Marketplace. There's sometimes people are transitioning to Medicare, in which you can reach the Choices program. These are all very vital questions for a lot of people who are going through this process, is how do I take care of my family and myself, both financially and health-wise? Emotional challenges. Well, for brain tumors, it's been impressed upon me just how much it is your identity. This is who you are. This is your signature you may be losing. This might be your ability to drive. It might be tied to your passion. And I think anytime I've worked with individuals who have had a brain tumor, there's been sometimes losses, and there's also been that work to connect to what makes them feel good about life, what makes them feel passionate and resonate. And this is something that our support group talks about in terms of how do you connect to gardening, even if you have a little bit of limitations in terms of balance, you'll find a way, and that work is there. The two emotional processes that I typically see, I tend to focus on very natural emotional processes. That this can be a traumatic event, which triggers our fight or flight survival mechanism. A lot of times I see people in the crisis stage where I'm hypervigilant, I'm having difficulty sleeping, I'm a little bit more irritable, and I'm picking fights with my loved ones, which is all normal because of the fact that you're in fight or flight, you're primed for it. Things are a little bit more difficult. The problem is when it becomes cyclical and it taps into anxiety and becomes a habitual process. Then we need to find a way to sort of address it and find ways to sort of pull you out of fight or flight. That could be meditation, it could be yoga, and there'll be other resources I'll talk about at the end that you can connect to. The other part is the grief process. And I'm a broken record with this one because anytime any person hits a limitation, they suffer a grief process. And so this is something we can't take a pill for, we can't avoid. It's really about feeling it and then doing good self-care, not getting stuck in it. And so I really spend a lot of time with individuals talking about where is your safe place to feel these emotions? Who do you have to talk to about this? And a lot of times it's our spiritual practice because it sort of addresses it existentially. So this might seem strange, the unsought gifts of a brain tumor. It's been remarkable how many people who have gone through such trials and hardships and loss say they wouldn't change a thing. And that's just an amazing thing to hear, because what they've gained from this experience, their gratitude, their appreciation, their recognition of what is most important in their life is irreplaceable. And it's not anything that can be replicated. It really taps into why we fight and what makes us happy, and it makes us more authentically ourselves. Some people have shared, like, I wasn't happy before, and now I'm spending my time baking bread and doing photography. And this is one of the things that comes from this experience. It's life altering. And part of the work that we do is making sure that people access what makes them happy, what gives them purpose. And, when we hit limitations, how do we transcend? But just a note for the caregivers, because there's a profound feeling of helplessness being a caregiver. I like to tell them they're doing a great job. They're just being there, being attentive, being attuned. They're doing enough. And then self-care, just in terms of putting two moral virtues together, you can never win. So it's really vital for both patient and family to spend time being self-full and taking care of themselves. So resources that we do have, we have the Brain Tumor Support Group. It's every third Monday, 3 to 4 by Zoom. You can reach out to me. I can add you to the listservice. We also have a caregiver support group that is the first and third of every Thursday. It's in the evening to make it a little bit more accessible, also by Zoom. We have the meaning-centered psychotherapy group, which is really how do you tap into the meaning through adversity. We also have a cognitive behavioral skills group for cancer survivors run by Dr. Kilkis. I put her email up there, so if you'd like and you're interested, you can email her for the next session. Additional resources, we have nutrition, any way to help you guys holistically take care of yourself, support yourselves stronger as much as you can. We have yoga, guided imagery, meditation. A lot of this is by Zoom, unfortunately, now. We do have art therapy classes. We also have parenting at a challenging time. This is specifically for parents with younger children who want guidance and ask questions about communication, developmental stages, and how to share with their kids what they're going through. There's also palliative care, which is a very comprehensive team comprising psychiatry, psychology, chaplain, social worker, nurse, art therapy, the whole gamut. And they can be very supportive and helpful. Community resources. The Connecticut Brain Tumor Alliance, they provide education and peer support. You can give them a call. You can just speak to somebody who truly understands what you're going through and will help you through. For cancer, there is Anne's Place, Cancer Cares, Kids Hugs for families with children. There's the American Cancer Society, which has a lot of educational information and also some supports in terms of staying, like if you needed to stay and receive radiation and consistent, you were local, you could access some of the resources. There's Family Reach for cancer patients, which provides free financial planning with an advisor. There's a Livestrong program, which is allows people to go to YMCAs for a tailored physical exercise routine to help strengthen their body. There's Cancer in Careers and Triage Cancers, which it really helps people navigate rejoining the workforce with a cancer diagnosis, and it gives a lot of excellent resources. There's financial grants for cancer patients. There's Connecticut Cancer Foundation and the Cancer Cares for brain tumor specific. There's the Lovemark Foundation and also the Connecticut Brain Tumor Alliance. Just a closing note on for me, occasionally people do require additional assistance. And for the younger patients I've been seeing, that's the personal care waiver program. The one thing that I've noticed is the wait list is 4 to 5 years. So if you ever have an opportunity to call your state representative, please do and say that's really unacceptable. For older individuals, 65 years and older, there is the Connecticut Home Care Program, and this is long-term care assistance at home, which is sometimes needed. So these are the resources that are available. If you have any concerns, reach out to your team. They will guide you to somebody that can help support you in any of these areas. I just want to thank everyone for the opportunity and just some references. And I had no disclosures. Thank you, guys.
Thank you, Brian. It's always such a beautiful talk and to hear you speak so passionately about it. And thank you again to you and to Jillian for the support group. One question, are our support groups open to all patients or only those being treated at your institution? Absolutely open to all patients. And so the more the better. And Brian, I don't know if you want to put your contact in the chat, or do you want to put my contact in the chat, or whichever, but please reach out to us, and everybody is welcome to come to the support group, and it's virtual, which makes it really easily accessible. All right, Bruce, back to you for those 2 tough questions. So how does CyberKnife radiation fit in, and what actually is the radiation as compared to an X-ray or dental X-ray?
All right, thanks. Yeah, great question. So CyberKnife is really just the name, like a brand name of one of the machines that does that stereotactic technique, which is 1 to 5 treatments. There's quite a bit of advertising around that machine, especially in Connecticut, with some of it good, some of it I think a little misleading and things that are kind of implying, but it's a very nice machine and does a great job. There are other machines that are equally as good and are actually more flexible. So for example, that Stu protocol with 6 weeks of radiation, that's not possible with a CyberKnife. It can only do the short treatment. So it's a great tool in certain programs. You know, we used to have one in our system up in through the St. Raphael's group that joined, but ultimately we decided that we like the machines that are more flexible, that can do the stereotactic and can do other treatments, and focus more on those. So a good machine, but with some limitations.
I think, I mean, Gamma knife radiosurgery essentially is the same. It's just stereotactic radiosurgery. Maybe one thing, right, if you could mention, I'm not sure if this is what the person was asking, but I think a good question that I always get all the time is why can't you use radiosurgery for GBM, whether it's CyberKnife or Gamma knife? Why do you have to use so?
Yeah, no, that's a good question too. So yeah, the Gamma knife, which we do have at Yale, you know, wonderful program with Dr. Veronica Chang, Neurosurgery, and then others helping out from radiation oncology and so on. But that machine uses radioactive cobalt sources to all focus in. It's really best at doing the single fraction treatments. It can, at the latest iteration, can do 2 and 3 treatments, but it's probably at its best with the 1 treatment. And we especially use it for brain metastases. We have other machines, like the machine I was showing at the beginning of the talk, those linear accelerators that can also do it, but I'd say that's our #1 machine for it. You know, what's interesting about tumors is that radiation is remarkably effective at a lot of different tumors, but it has its limitation. There's just not enough dose that we can get to, and sometimes we've studied what are called dose escalation trials, where we try to go higher and higher with this more sophisticated machinery. And sometimes you find that, it just doesn't work better. It either isn't as good as, or no better than the lower treatment, or in fact, it can be worse sometimes because we have more side effects and we're still not, controlling the tumor any better. And so for glioblastoma in particular, I think in the earlier days of Gamma Knife and some of the machines, people were saying, hey, this is a tumor that we're struggling with, and we didn't know as much about some of these MGMT and all these nifty things that Dr. Corbin was pointing out. And so one thing was say, hey, let's do more radiation. And I would say pretty uniformly, those efforts and trials were failures. They just did not replace, they certainly didn't replace what surgery can do. And even within radiation, they just really weren't adding a lot. So at this point, we very selectively use radiosurgery techniques for people who've had usually multiple recurrences where they're not a surgical candidate. I think in that respect, and there's been a gap of time since the original radiation, it can be quite effective there. And we're studying it in combination with certain other drugs to see if we can make it more effective. But definitely not a substitute for surgery when at all possible. The other question, so most of these machines that we're talking about, whether it's CyberKnife or a True Beam or any of these ones, are using X-rays, really X-rays. The Gamma Knife machine uses gamma rays because it's a radioactive pieces of cobalt, but most of them are these machines, and so they really share a fundamental architecture with the same machine in your dentist office or a mammogram or anything else. The difference is that those diagnostic X-rays are in the kilovoltage range in terms of the energy. And when we treat with therapeutic radiation, the megavoltage range. So it's 1,000 times more energetic and really has some unique properties about how it can damage the tissues, and which then sets up the type of shielding that's necessary and everything else. So they are X-rays. They're just more powerful that we're using.
Great, thank you. There was one final question with regards to surgery. Somebody who's watching from Germany, so thanks for joining from Germany. Question, do we have any thoughts on the autologous omental free flap technique from Dr. John Bookvar, and has this been done at Yale? And so John is a good friend of mine, and I'm familiar with his trials. This one is something just to update others about. This is using a piece of laparoscopically obtained omentum, which is highly vascularized with a pedicle, a vascular pedicle to it. And the idea there is to bypass the blood-brain barrier. And he's had some other trials that have that same type of thought behind them, bypassing the blood-brain barrier to get more direct targeted therapy to the resection cavity. We personally don't have that trial here. We haven't tried that trial here, but we'll certainly look to John and his team to see how the results are early on in that trial. I don't know if Zach, you have any thoughts or comments. He does not. All right. Well, it is 8:07, and I think we are done with all of the questions. It's really been a pleasure having my friends and colleagues here tonight. So thank you again to Zach and Bruce and Brian. Really wonderful talks, really a pleasure to work with all of you. Thank you for everything you do for our patients as part of the Brain Tumor Center. Thank you for being here tonight, and thank you to everyone for listening to us. And please reach out anytime. Brian put his email in that chat for the support group, and you can email me at any time with anything. All right. So have a good night.
Thank you so much.
Good night. Thank you.